just over your ear.
Yeah.
Kind of adjust that. Closer the better.
Right. Okay. I can just click it on and we're good to go. All right. Good.
Yeah. Hi. Nice to meet you. I'm Mike Cusick. That's my mom.
Hi, Mike.
Norma Cusick. I'm an ophthalmologist out in Reading area.
Okay, yeah. She talks about you.
She says great things about you. So she said, you got to meet this guy. He's really great. So I wanted to come over and just hear you talk a little bit.
Thank you.
I'm getting my MHA down at the MedStar Health Complex down at Georgetown.
Yeah, absolutely.
So I'm sort of delving into this,
Getting into the
triple aim, which is interesting coming from a private practice world. I see the challenges. I totally have a much greater respect for the people who are trying to incentivize some of the changes. I don't know. I totally see it from my end how these changes are so challenging that it's going to take a generation to kind of change.
Well, it kind of does. You know, they're for people to it's gonna shake them up.
Exactly. Yeah, which I think is good. I mean, I totally do. I think it's great.
Any change management, it's going to take effort. It has taken effort. And we're on this road. We've been down this road for probably.
We need to wait 30 minutes for Terry to get her mic on.
Yeah, okay.
And the culture change. You really are.
Yeah, I mean, you
maybe talk about it a little bit. You know, like an emergency medicine change, right?
Yeah.
So emergency medicine usually, how many more ED beds?
right now. Exactly.
So an understanding what kind of financial impact that has on your organization, rather than just go along with it. It's been a fun time.
It's great. Yeah, great. I do have a specific thing. One of the things you guys have started here, which I don't know how to get in touch with them, but do you know Brian Shablin? He's a primary care doc here.
He's a primary care.
He started your telehealth retinopathy screening.
Okay.
In the primary care offices.
Okay.
I just put my email here with his name on the back. If you are able to link through your network and email with him and shoot him my information, my master's project is going to be focused on looking at creating something like that in a place that doesn't have it.
Great.
So what's the activity-based count and all these sort of finances that go into creating a telehealth network for ophthalmology specifically. And he has already, you guys already started something like that with your screenings in primary care offices. So I would have that kind of twist to it.
What we'll do is I will reach out to you.
Is she okay now?
She is, yes.
Great.
Yeah, great. Next thing
All right, I think we might be ready to go.
Hey.
Okay.
Oh my God. Two of my favorite people in the whole world.
Okay, folks. Ooh, the mic's working. Can everybody hear? Okay, Max, the tech guy, is here in the back. So if you can't hear, he's going to do whatever he can do to make sure you hear what's being said. So good afternoon, and thank you for attending today's Board of Associates meeting, general membership meeting. It's the first meeting for 2019, and I'm so glad so many of you came out with this bad weather and ventured with all the ice. So be careful going home. I wish to particularly acknowledge and extend a warm welcome to our guests, and I'm so happy I met a couple of them that we have some guests today. I'd like to ask each host who brought a guest to please introduce their guest and wait for the microphone to come to them. So raise your hand if you've brought a guest. Ooh, ooh, oh, how nice.
Do we start now? I'm Dr. Richard Cusick, and I'm retired now. 43 years ago, I was a resident physician here when the hospital opened, one of the original group of pioneers. I'm a member of the Board of Associates with my wife, Norma, who serves on the board. And we're privileged today, Norma and I, to have our son here. 15 years ago, Dr. Michael Cusick, who's sitting next to me here, was a member of a residency group then. And in the 15 years since, he's been practicing after he finished his residency and fellowship in retinal surgery. He's been practicing in Reading. And so we're very pleased. I'm very pleased and humbled to introduce my son, Dr. Michael Cusick from Reading, Pennsylvania.
Okay. There's one.
No, it's okay. Hello, everyone. My name is Ann Panic, and I am a member of the Board of Associates, and I'm delighted in that I have a guest. This is Charlotte Buckenmeyer. Some of you may know her. She is recently retired from Lehigh Valley Health Network, where she served as director of the emergency departments at Cedar Crest and at Muhlenberg, and most recently, prior to her retirement, in the pre-admission testing area. So I'm delighted, and especially with the topic of the day, we think it's a great fit because we do love the ER.
Good afternoon, I'm John Dubbs, and I brought my wife today to introduce her to the board and to find out how she can help get the word out about what the Lehigh Valley Health Network is doing and can do. She was also curious about the literature that came in and saw my name in the directory, so I said, this is your chance. My wife's name is Ann Stewart. She's a realtor in town with RE/MAX, a wonderful involved lady in our church and the community, so I'm thrilled she's here. Thank you.
Hi, my name is Sandra Mulig, and I'm one of the board of directors, and I wanted to introduce Linda Dyke today. She's a very special lady. She's a registered nurse, and she has a pediatric clinical specialist. She's a nursing instructor, a healthcare planner, and she has BSN, MSN, and an MBA. And here's Linda Dyke.
Thank you, everyone.
Okay, a lot of letters after that name. Well, we have 4 guests today. That's wonderful. Okay. All of your members now have received or will be receiving shortly your 2019 membership directory. I got mine on Monday in the mail, so yours will be coming. If you did not receive the documents, they're available at the registration table, and please let our executive secretary, Erin, who's standing back there, know if your contact information has changed. Now it is my pleasure to introduce from management Executive Vice President and Chief Operating Officer, Terry Capiano.
Thank you, Jean. Thanks, Jean. Really love, I tell all of you, for those of you that are new, every time I start this particular presentation about what we're doing here at LVHN, I preface it by saying, this is my favorite meeting. I love to come to this meeting. And I like to do this. Actually, I love to do this because you are basically our ambassadors out in the community. So you have a passion for LVHN, just like I have had a passion for LVHN for over, oh my gosh, now I'm going to say over 35 years. So we'll just leave it at that. Pretty soon I'll have to up that. So what I wanted to do today was to talk a little bit about some updates of where we've been and kind of where we're going at LVHN over these last couple months. And we have such exciting information to share. The first thing I'm going to share today is what I think is our best kept secret. And that is our, and I'll put the emphasis on it, our Lehigh Valley Riley Children's Hospital. And we'll talk a little bit about that. As you know, we have transformed our children's hospital to the Riley Children's Hospital through a generous donation by the Rileys, by Kathleen and J.B. Riley. And so this is our new name. This is our new logo. The logo has always been the same, but Riley will be in front of all of our children's hospital media and public names and logos on this. So it will always be referred to as this. I think our children's hospital was actually the best kept secret. We have had a children's hospital for years and years and years. And it was our best kept secret. And you'll see as I go through these slides, what we thought we'd do is just give you a little trajectory. We didn't just develop a children's hospital 10 years ago or 20 years ago. The seeds of it began with our first practice in 1948. That was our first pediatric practice in this area in 1948. And as you look at, and I won't go over every single little thing, but I want to highlight some things about this. As you look at this slide, and we take you from basically 1950 all the way up into 2012, and then I'll do the last 5 years on the next slide, you can see the strides that we made in medicine, in clinical care, as well as how we applied that to our children's hospital. So you look at, if you just kind of glance through, throughout the top, you look at some specialties that we've added: pediatric oncology, pediatric cardiology. We have about 30 specialties in pediatrics that we've added over the years. And that's what makes a children's hospital. You have access to specialists that you wouldn't otherwise have access to. So you look at our first neonatal, so newborn, neonatal intensive care unit opens in the 70s. And that was over at 17th Street for those of you that delivered there or had your babies there. I know I had my babies there. And then we opened our new neonatal intensive care unit in 2000 at the Cedar Crest site. And then we opened a pediatric intensive care unit, the first in this region, just a few years later. And you see how we expand: cardiology, oncology, sleep medicine, gastroenterology, neurology. I mean, you keep expanding what you're able to offer. Importantly, so I don't want to gloss over this, where it says we have in 2012, we added a pediatric residency program. So lots goes in to adding a residency program in your organization. But the importance of a pediatric residency is you are on the top of your game. And you just went through a residency probably not all that long ago. But your professors, your teachers, your mentors, the physicians you look to, you are at the top of your game when you have a residency program, because you are teaching others. You are teaching the next generation of pediatricians, of pediatric specialists, how to practice medicine and how to practice healthcare. So very important. Residencies are so important for a whole host of reasons. But I will say that it just keeps us sharp with quality, with service, as we're teaching the next generation how to be specialists in the organization. So here's the last 5 years, and here's where we've been over the last 5 years of our trajectory. When it says up there that we're an institutional member of the Children's Hospital Association, there are a couple words, but that is years of work, years of building our repertoire in terms of the specialists that we provide, years of building our pediatric practice, years of building the quality that is around it. And I will tell you that Dr. Nate Hagstrom, I believe he's been here to talk with you before about all of what's going on in pediatrics. He is a stickler for quality. He is one of our top-notch physicians in quality, and he measures everything. What he wants is a highly reliable service to the children and parents of our community. Being a member of the Children's Hospital Association is a big deal in terms of the quality that we provide, that we could get in to be a member of that prestigious organization. And then you see some other things on this trajectory that we have. An advocacy center, that's a program for children of abuse, all kinds of abuse and neglect. And so we opened that advocacy center in 2017. We opened our children's services at Muhlenberg with our level 2 neonatal intensive care unit there, as well as our family birth and newborn center. Here on this campus, next to our glass building, so if you look at the hospital, and I'll show you some renderings, but if you look at the hospital front on the left is that glass building that is now totally devoted to children. and to children's care. To the left of that is our 1210 building, and that's where we opened a surgery center dedicated to children. Children are not little adults. They have special needs, and they have special health care approaches to them that are different than the adult world. Specialty care close to home does not just mean new buildings, does not just mean intensive care. It really means a full array, starting with anywhere you want to start with. The pediatrician's office, starting with emergency department care, starting with express care. We now have express care at our Palmer Township location. But really doing things like pediatric surgery and pediatric anesthesia. So you don't think of that. But truly, we want anesthesiologists that are schooled, trained, educated in the art and science of pediatric anesthesiology. So our programs go well beyond what you would think in terms of just what the building says, and it goes deep into what we're able to provide the children, the families, the parents of this region. Likewise, let me pause here. So this is the building, as I was saying. This is our Jandal Pavilion. And you will see as we start moving all of our services into that Jandal Pavilion, how we stratify them and how that total pavilion is dedicated to the care of children. You know, as you walked in, we have a lot of construction going on. We want a dedicated opening. We want a dedicated lobby. We want people to know they're coming into a children's hospital when they access our organization. The very newest, as you see on the very top level, on the 5th floor, is our newest inpatient pediatric unit. All of our units, I'll give you a little peek at that. All of our units are, brightly colored. They're done in jungle and animal themes. This particular unit, each room has a color and is associated with an animal. So there might be like blue bears, red rabbits, those types of things. And that's how we refer to the rooms, rather than 510. Like how uninspiring, right? We're in 510. More. I need to be louder. I never get that, ever. So we wanted the rooms to be special and to appeal to children. Likewise, not only will we get a facelift at our new building, or our new lobby entering into our children's hospital, but we will also get a little bit of a facelift on our children's surgery center. And that building not only houses our surgery center, but also houses our oncology center for children. That entire building used to be just a doctor's office building, and it is now totally dedicated to the care of children. And it's great to have lots of different intensive care areas and express cares and emergency departments. It's equally important to have programs in the community dedicated to the care of our children. As I talked to you before, we have our Child Advocacy Center, and we have a physician that specializes in childhood abuse and all types of abuse. It is amazing. I made rounds over there just recently, and it is amazing the number of families and children that she sees through that center. We have other different partnerships, and one of the ones, our school health program, we're in the schools. We have physicians and nurse practitioners in the schools taking care of elementary school children to give them a good start in life. It really helps to catch people, human beings, and their children. Those little human beings are children. Important to catch them early to make sure they develop good health skills. Likewise, we acquired the Weller Education Center, and that was something that many people knew throughout this region, but we acquired that a year ago. And that program, in terms of providing wellness education to children throughout our school districts, throughout our entire network, throughout our entire region, has just been amazing. It has grown and flourished and developed as part of LVHN, and we're delighted to have that available to us. A few short months ago, we actually dedicated the Riley Children's Hospital, and it was a fabulous day. As I said to the Rileys, I almost didn't know what to do with myself. You know, you wanted to clap your hands. You wanted to be like you would be at a football stadium. You wanted to kind of stamp your feet and clap your hands and hoot and holler. Because it is just such a wonderful thing. I used to tell the Flemings this all the time. With donations such as theirs, it allows us to dream, and it allows us to dream big. And we can make those dreams reality when you have the resources to do that. When you have, you know, the programs don't materialize overnight, right? They take money. They take resources in order to make those things happen. And in order to do things in this region that nobody else does. It really does take somebody that's passionate, as passionate or more passionate than we are about a single cause, and help us bring that cause to reality. So you can see all of our staff was out, everybody's hanging over the second floor to cheer on the Rileys, to recognize them for their donation and their naming of the Children's Hospital. Pretty much a fun day. And it will all culminate when you look at our organization here on this campus. This will be the icon of our Children's Hospital. You will see a brand new lobby. You will see it well lit from I-78. It will have a separate entrance that looks like you are entering an organization that is dedicated to the care of children. So not only this building, but as I showed you, the Hecht Specialty Center, that building also will have branding, and you know when you enter that building that you are entering a very special place to take care of children with cancer and children that require surgery. So let me not just go on and on about the Lehigh Valley. I also want to tell you that we're expanding our care to our Schuylkill region, and we just opened our family birth and newborn center in Schuylkill as well. So 15,000 square feet with labor and delivery and triage rooms, and a place where families get a healthy start. Likewise, continuing our theme of health specialties, getting to people early, the mobile stroke unit is one more mobile service that we provide. So we provide a dental van that is mobile, that is dedicated to the care of children needing dental care. We opened and have put on the road our mobile mammography unit in October. And I will tell you that pink van is all throughout the network. Every day it is busy. Can you imagine that? Every single day we are totally booked up in that mobile mammo unit. Many of the times it's for convenience. Hey, it's easy for me to go into that mobile van when it's up near my place of work or my residence. But most of the time, what we are caring for is a population that did not have access or could not get to that diagnostic modality that those of us over 40, and I know I'm just a hair over 40, but those of us over 40 should get a mammo every year. So I am just overwhelmed at how busy that unit is when we take services to people and invest in that, how busy that mammography unit is, number one, and number two, what we're finding on screening, because it's people that didn't have access to that modality. So now let me get to this modality. And 2 weeks ago, we unveiled our mobile stroke unit. Dave Burmeister, who you will hear from, Dr. Burmeister, in just a little bit, we helped to unveil that with Citronia Ambulance. And think about stroke. Every second counts. Every single second counts in stroke. So if you think you're having a stroke, we wanted to get that care to you right away. So in that mobile stroke unit, I thought I included a picture, excuse me. In that mobile stroke unit is a CAT scan. So in your driveway, we can put you into our CAT scanner. We have an advanced practice clinician in the truck with all of the EMS people, and they have a direct line to a physician on call that can see what is going on in that CAT scanner, can see the diagnostic, and treat patients, begin to order what that patient needs in terms of an intervention. All those seconds, all those minutes matter. Doesn't matter if we're talking about your heart or your brain. Seconds matter, minutes matter. When it comes to treating you, and when it comes to an intervention. So we accumulated those resources and began to think, and I think that's what I want to get across, is you begin to think, what is it that we can do for this community? How is it we can provide services to the community unique from anybody else in this region? So number one, Children's Hospital. Number two, take services to people, invest and take services to people where people don't have them. And this was another day I was almost beside myself with the mobile stroke unit, knowing that, and I said, I can't wait till we get to, and it'll be on the road in April. I cannot wait. Lots and lots of testing. Lots and lots of testing has to go on. We're doing something very different. But I can't wait till we have our first story. That first story is just going to be fabulous, that we got to intervene in somebody's driveway or on the road back. So if you live 20 minutes away, you're getting that intervention 20 minutes sooner than you would have before. And you might say, well, what's the big deal about 20 minutes? It's a darn big deal. It's a darn big deal when it's you. It's a darn big deal when it's your loved one. And it's a darn big deal when we look at how you may function after a stroke versus before. Another new area for us is we opened our Hausman Road building, totally dedicated to orthopedics. So physiatry, rheumatology, pain management, and our orthopedic physicians. They were so busy here at our, for those of you that have been to the orthopedic office here, very, very busy, so that we needed to expand and kind of move them off the campus so people could access them very easily. Very close to our Tillman Street Surgery Center. And last but not least, oh no, this isn't last, second to last but not least, you saw in the paper an unveiling of our new Northampton County initiative, and that we are going to have a hospital there as well as a medical office building providing primary care and specialty care on that campus. So stay tuned for groundbreaking there. It's very, very exciting for us to be able to offer those services in a market that we've not quite been as visible in before. And I could not mention February is Heart Month. And all of you see all of our billboards and all of our advertisements throughout the region is focused in on heart, one choice. We have the trees out front, which will be lit in red. And we also have the American Heart Association. They knit over 600 caps for our newborns. And so our newborns in the month of February go home with a nice little red cap in recognition of Heart Month. So I'm going to pause there and ask if you have any questions about any of our new services. Yes, or anything.
When you have a dedicated person on call to take the response from the CAT scan, is that person in the emergency room? Is he in a special unit? How does this work?
Yes, well, and the special person is a neurologist.
Okay.
Right? So that's the special person, number one. And number two, Dave, where are they housed?
They can actually
be anywhere, right?
They can be anywhere. Yep, they can be at their home. Yeah, they can view the images from their home even, so that we're not wasting any time. And there's always a neuroradiologist available 24/7, 365 within the organization as well, which is housed at Cedar Crest.
So then when the patient is brought in, they're brought into the emergency room.
Yes.
And then they're directed from that person, wherever they are located, to the emergency docs.
And as Dr. Burmeister said, then we have somebody that can actually, if there's another intervention that needs to be done, and interventions are done in a place called interventional radiology. If there's another intervention that needs to be done other than medication, we have somebody on staff 24/7 to provide that care. That's why we are a comprehensive stroke center. We have an accreditation that is called comprehensive stroke because we provide the full array of services.
Okay, thank you.
You're welcome. Thank you for the question. We have a question. Oh, we have a couple questions. Okay.
Well,
there's somebody with a microphone. We'll get you a microphone.
I'm sorry.
That's
Well, so will the Children's Hospital have its own ER for children?
Yes. So, Dave, I didn't want to steal his thunder.
Yes, sir.
Dr. Burmeister will be talking about emergency services, and he'll talk about our children's ER as part of that. But yes. Now, we have a children's emergency department today. We have one, totally dedicated to the care of children. You come in through the same entrance. And that's why people don't know it. I won't steal his thunder for the future.
How you doing? I just want to clarify in regards to the mobile unit. So are we going to get any more coming in? Or are you going to do it as, let's say example, we're in Easton, you're going to go to the closest area?
So right now we're working with Citronia Ambulance. So we only have one of these.
Right.
Right? They're about $1 million to build. So we're working with Citronia Ambulance. So right now it's really centered around the Allentown, Lehigh County market.
Okay.
So we're not in Easton or Bethlehem right now, just because only one, and we're going to try it out. And I don't know what we'll do in the future, but we're hoping to have good outcomes with this one, and we'll see about the future if we can do more.
Hopefully we can get some bigger sponsors and get some more.
Yes, you bet. You bet. Aaron, we had a question here.
Thank you. With our Lehigh Valley population of, say, around 500,000 people and one mobile stroke unit, on the day when you get more than one 911 stroke calls, what determination is used, what criteria, where the unit goes?
Well, if the stroke unit is already responding to another call, then it won't respond to this call. It'll be service as usual in terms of getting the patient in the ambulance and back. And the thing that's unique about the stroke unit is we can do the diagnostic right away. All of our EMS ambulances, all the ambulances have a direct line into the emergency department. So the doctors know what's coming in before it comes in, so they can be ready and prepared. Dave, do you want to answer that?
Yeah, so we actually have had for quite a few years, we have a pre-hospital stroke alert process. Hi, everybody.
Come on up, talk about stroke alert.
Yeah, so the pre-hospital stroke alert process, so anytime EMS is notified of anybody with stroke symptoms, when the paramedics get there, they evaluate the patient and determine based on criteria whether they're a pre-hospital stroke alert. What that does, even while you're at home, that activates the entire system within our organization. So radiologists, emergency medicine physicians, neurologists, everybody is notified ahead of time. Actually, before the patient even gets to the emergency department, everybody's there waiting for that patient. And we actually have a very rapid process where we get patients directly into CAT scan now, too. You don't even go into a room. You basically go right there in the hallway when you come in. We say hi to you, take a look at you, do a quick exam, and get you to CAT scan. So we already have a very comprehensive process. This will allow us, to Terry's point, 20 extra minutes is a huge deal for a stroke patient. So I think it's a real opportunity for us. A lot of the logistics we still need to work out, the communication between all the other EMS agencies, other counties, and other logistics, but we're really excited about it.
Is this a good handoff?
Yeah. All right. Right on.
Well, Jean will introduce you. Thank you.
Sorry, Jean, I don't want to get in your way.
Well, I have a question.
Oh, you do? Okay.
Since I volunteer at 17th Street, I
Yes.
see a lot of children coming into the clinics there.
Oh, yes.
Are they then referred, if something is terribly wrong, are they then referred to out here?
Oh, absolutely. Absolutely. I love 17th Street,
So do
right?
I.
We all love 17th Street. Because why? Because we take care of children and families, and that place is robust and busy and bustling all the time with family and children. So we have a large clinic there to take care of the children of our community. If there is something wrong with a child, they will be referred to a specialist. Yes.
Okay. All right.
Thank you, Jean.
Okay. So you answered that question.
I did.
One of the problems One of the problems I have with the new Children's Riley Hospital, I can't make an acronym out of it. Children's Hospital of Philadelphia, you can say CHOP. I've tried switching all the letters around. I can't come up with anything. So, and then the second comment I want to make is a couple weeks ago, my family doctor is out in Houseman Road. And I went on a routine visit out there and I thought, what's this? Lehigh Valley Hospital took over the building. And I went inside and the whole first floor was being remodeled for different units. And I had to come back 2 weeks later, and when I came back 2 weeks later, I couldn't find a parking spot. The place was just crowded with cars, and the first floor, they were standing in line to go into all the different units there. But Lehigh Valley Hospital's symbol on the front of the building, and I said to my doctor, did you join them? He said, well, no, I'm in the physicians group, but not with Lehigh. Well, anyhow, so those are my personal comments there. Okay, thank you so much, Terry. Okay. Now it's my pleasure to introduce, who already talked a little bit, our featured presenter, Dr. David Bernheiser. In the back of your agenda sheet, you'll see his bio. It gives him more time to talk if you read that yourself. On a personal note, yesterday I talked to somebody, and I can give a little reference on him. The party I talked to said he and his wife are one of the nicest people that he has ever known. And the person who told me this was a member of our Board of Associates. So now I introduce Dr. Bernheiser.
Thank you, Jean. Thank you very much. Terry, thank you as well. Okay, great. I like to walk around and move around, so forgive me, okay? So I tend to jump a little bit, but I definitely wanted to give you an update on the Department of Emergency and Hospital Medicine, where we are right now and where we're headed. And so there have been a lot of changes, and when I realized that Charlotte and Ann were going to be here, I was like, I better be on top of my game, because we have worked together for many, many years since the first day I've been here. And we've come a long way, right? We've come a long way together, and it's really amazing because we're taking our next step into the future and trying to sort out where's emergency medicine and hospital medicine going. Just to give you a little bit of a background, we merged the emergency physicians and the hospital medicine physicians, which are the doctors that take care of you on the inpatient units. They take care of about 80% of the inpatients that come through our system and come through all of our hospitals. And the emergency physicians who will take care of you when you come into the emergency department, we merged them because we felt that there was an opportunity there to be more efficient in the way we've treated patients and to try to get them the right disposition and the right treatment quicker than before, and it's been very successful. So right now, this department is made up of about approximately 160 different physicians. When you look at emergency physicians and also hospital medicine physicians. We have about 130 advanced practice clinicians, which includes nurse practitioners along with PAs who also take care of you along with the attending physician. We have multiple residents, emergency medicine residents. We have one of the largest in the country. It's about 58 residents, which is very large, and a really large internal medicine residency as well, which is housed in the Department of Medicine, but we interact with them on a very, very regular basis as we do a lot of their clinical teaching up on the inpatient units in hospital medicine. We have hundreds of nursing staff. We have scribes, tech partners, radiology techs, CT techs, and consultants. So to start the conversation, there are many, many people that come in and out of an emergency department every single day. We take care of across the network around 305,000 visits per year. And that includes Pocono, that includes Schuylkill, and that includes Hazleton as well as the 3 campuses that we have here. We have 7 emergency departments, and we admit almost 58,000 inpatients every year that comes through our department. And so we touch patients' lives in a real way, and we understand the challenges that we have, too, at each site and what we need to do to try to be more efficient with their care and try to treat them quicker, try to get to our patients in a more timely fashion. And so, we really have a lot of trends, though, in emergency medicine and in hospital medicine that we need to pay attention to. So the national trends. So what is happening now? So back in the day, I think when I started emergency medicine, it was, look, we knew every year that there were going to be more patients in the emergency department, right? We could almost count on an increase in emergency department patients. Well, since that period of time, a lot of things have happened, right? We've put express cares in place to try to take care of that lower acuity patient. We've opened up outpatient access, and we've done that very successfully here at LVHN and our LVPG practices. And quite frankly, we have a lot of challenges. There's overcrowding issues that have happened. We've seen a decrease in the total number of hospitals across the country, because what we're realizing now is that we have to be more efficient, and a lot of hospitals couldn't do that. And so they basically went out of business, right? And they had to close their doors. So there has been a lot of consolidation that's taken place. So what does that mean? That means less emergency departments, and that also means less inpatient capacity too, as well, at the same time. So there's been a new trend lately, right? Micro hospitals. So there are a lot of small micro hospitals that are popping up all across the country, all across the region. How will that change? I can guarantee you probably in the next 2 years, when I look at the EDBA benchmark, we'll probably have a slight increase in EDs. Now, it doesn't mean that they're high volume, high acuity EDs like we have here, but they still will be access points for patients. So we may see a difference there. What we're seeing in emergency departments now, this is the first year, 2017, that we saw a flattening of ED visits across the country. Every year for the past 15 years, we've seen a 2% increase. Boom, boom, boom. And urgent care has really risen, even with a 2% increase. This is the first year where we've seen a flattening. It's been pretty much flat as far as those visits across the country. And we see about 150 million ED patients across our emergency departments in this country. So the problem is patients are sicker. They're much sicker. Their acuity is higher. There are more resources that you need to be able to utilize to take care of those patients more efficiently and in a more comprehensive way. So you got to be on your game. You don't have a break. There's not a break for a lower acuity patient anymore. They're all very, very sick. And that's why it's more important for us to be even more efficient as we move forward. Our population is aging, which is a great thing. But with that come complex medical problems, right? Different medications, new types of problems that come into the emergency department, new complaints. And so that's going to be very important for us. And then there's the consolidation of inpatient beds. So it's not anymore you can't have a 1,000-bed inpatient unit and be utilizing 700 of them. So hospitals are closing and contracting their inpatient units, rightly so, right? Because it's more cost effective, it's more efficient for patients. So what do we have to do? We have to decrease our inpatient length of stay, right? Try to get patients home safely and in the right manner, and then be able to accommodate all the sicker patients too at the same time. And there's a balance there, and we have to listen to that balance. And then certainly the unpredictability of our patient volume, which happens frequently. In emergency medicine, we have some trends, but we don't know 1 hour to the next exactly what's going to happen. And that goes on the inpatient units too. We don't know how many inpatients or how many sick patients that we're going to get as we move along. Now, I think that we're doing a better job, honestly, of population health management, much better here at LVHN, because we've been in this game for 8 years now. We've been paying attention to population health. We've been trying to keep people out of the emergency department, trying to keep people out of the inpatient units, because that's the right thing for our patients. How do we be more preventative as we move along? And we've put a lot of things in place, and we've expended a lot of financial infrastructure and a lot of clinical infrastructure to be able to do that in a better, more efficient manner. This is a great example. We have 17 express cares within our system right now. This is just a little bit of an idea of what would go to an express care and what would go to an ER. Now, certainly in emergency medicine, we can take care of anything. Whatever complaint you have, we can take care of. But we like to try to put people in a position to be able to make a choice on their own and give them options, give them a lower cost option, or give them another more efficient option than coming to the emergency department. So this is the list, and I put this list up here just so you could see what we usually do and what we try to at least talk to as far as the rest of the people that come in and out there in the community, so that they can take a look. What goes to the express care? What goes to the ER? Certainly if you're having chest pain or stroke signs or any other type of issues, you shouldn't go to an express care. You should obviously come to an emergency department. So keeping those things in mind are very, very important. Which leads us to another question. Right? Observation. Have you all heard about observation versus inpatient? Right? So it can be confusing, quite frankly. What's observation and what's inpatient? And all of this discussion that I'm having right now is really to kind of lead up to where we're headed and what direction that we're headed into. And it's important for us. Typically an observation patient, and when you're in observation status, you're really an outpatient. You're supposed to be here for less than 24 hours, and we try to get the diagnostic tests, and we try to get all the things that we need to get you efficiently in and out safely and into the right direction for your outpatient care. That's what observation means. When you're an inpatient, you typically stay over 2 midnights. You typically have more of a workup that you need. You need an echocardiogram, or you need an MRI, or you need some other type of study, and it requires a further teaching. It requires more treatment as we go along. And that certainly can be difficult for patients because you have to meet certain criteria to be an inpatient, and at the same time, it's payer dependent. So depending on your payer will depend sometimes whether you're an observation or whether you're an inpatient. But these are things that we're trying to take care of in the new world. We're trying to make sure that we're communicating with patients in a way, not just by voice, but by where you're headed, right, and what status you're at. Right now, if you're an observation or you're an inpatient here at LVHN, Cedar Crest, you'll still go to the inpatient unit. We have an observation area, right, that we try to efficiently move patients through, and we've done a great job at that, but it still sends the message that you're an inpatient. And I think those are things we need to fix moving forward. So what has been our plan in emergency and hospital medicine? Our plan basically has been to, number one, take a system-wide approach to this. This can't just be about an emergency department, or it can't just be about an inpatient unit. The whole system has to understand how important it is to evaluate and treat our patients appropriately in a very cost-effective manner and get them dispositioned safely home to where they really want to be. Nobody wants to be in the hospital. And so we're working very hard with our inpatient access team. And as I've learned more and more, right, I'm an emergency trained physician, but as I took responsibility for hospital medicine, I inherited the inpatient length of stay, right, along with a lot of other people within the network. And it was important to me to understand that system-wide approach, so we all have had to change the way we think. It's no longer the ED's fault. It's no longer the inpatient's fault, people's fault. It's all of our responsibility to fix this. And I think that has been very, very important for us. We've improved the intake and patient evaluation times of our emergency departments, especially at Cedar Crest. Muhlenberg, we put a rapid assessment unit in place. Charlotte and I built that unit a long time ago, didn't we? And it has had left without being seen times lower than any place in the country. It's just been incredible, and it's sustained itself. So we've done lots of different things to try to evaluate and treat our patients more appropriately. We have reduced ED observation and inpatient length of stay. We have a long ways to go, though. We're never done with this work. And that goes to the next one. It's a constant process improvement, right? We always have to be thinking about different ways to do things, because our patients aren't staying the same. They're all changed. They've changed. They're more complex. They're higher acuity than what they used to. We don't have the lower acuity patients. They're going to express cares now for the most part. So when everybody would come to me and say, "Hey, Dave, boy, if you could just get rid of all those patients that don't need to be in the emergency department," that's not the case as much anymore. There are some, and that's okay, because we'll see everybody. We'll see them all. Everybody come. That's okay. But let's try to educate people in a way that makes some sense. And that's not happening. The point is that is happening, and we're not seeing those lower acuity patients as much. Patient satisfaction, paying attention to the experience, and that moves into the next discussion we'll have. That is huge for us, right? I mean, if you're in a hallway, so we use hallway patients because we need to be, so it's the question, right? Well, okay, so do you have somebody wait out in the waiting room, or do you try to see them or evaluate them more quickly in a hallway bed? And it's a difficult dilemma, right? And we want to get rid of that dilemma. We want to put a patient experience together that makes sense for everybody in our community. And so that's the direction we're headed. And at the same time, it's not only just about our patient satisfaction. It's about our colleagues that work there, right? And so that is directly proportional and related to our patient satisfaction. And so that's another really important point, especially with emergency medicine and especially with hospital medicine, because there's a very high burnout rate in those specialties. So we're paying attention, and we're making progress on it, quite frankly. And this new plan will hopefully get to where we want to be from that perspective. Innovations in emergency and hospital medicine, virtual medicine. We're doing virtual visits now, right? You get on your phone and you can do a virtual visit. We do a teletriage now, right, where you can do a telemetry. We use a virtual medicine to be able to triage people that come into the emergency department. We use it in psychiatry and all the other specialties too, and we're doing e-visits now even in the practices. Point of care testing, now we're not sending labs the whole way down to the lab. We actually do it right at the point of care. So we get a lot of labs that are quicker, more efficient, so that we can get the answer that we need right away. So that's been happening. We're using a lot of ultrasound. Ultrasound's been revolutionary for the way we practice emergency medicine. It's been incredible, not just from a provider perspective, but from a nursing perspective. So everybody is learning how to utilize ultrasound, which is safer for patients, more efficient, it's quicker diagnostics, and patient gets their treatment quicker, just like the stroke unit, but in different diagnoses, in different ways. So that's been very helpful. And of course, the development of innovative spaces. Across the country, we're looking at neighborhood hospitals and how do they look, and how does the flow of the patient move through, and we're doing the same thing in emergency medicine. And that leads us to the next topic, which is what I really wanted to talk a lot about to make sure that you understood and you could understand kind of where we're headed. And that really goes to what's going to happen here on the Cedar Crest campus. And if you came onto campus, I don't know if you came into the front or the back, there are a lot of trees that are getting cut out back. And so Cedar Crest will be a brand new emergency and observation unit. It'll be one huge building. It'll be its own building with a lot of infrastructure inside of it. And I'll talk to you a little bit about what that is. When you come onto campus, if you've ever been to the emergency department, the back of the building is, you have an emergency and you kind of drive around. It's, a relatively small area where you can get dropped off. Now what will happen is that whole area will be part of the children's ER. To your question earlier, sir, there will be a totally specific entrance just for children. It'll look like the front of the children's hospital in lots of ways. It'll have different colors. It'll be very clear to the community that this is the children's emergency department, the children's ER, and this is where you go. And as you wrap around, you'll come into the adult area where there will be another entrance, a second entrance for patients as well. Different staff, different physicians, everything will be separate. Specifically, the investment was about our children and about the adults also that take place, and the observation patients, which are now considered, of course, outpatients. So this is what it'll look, as a rendition, of course, but this is how it'll look coming onto campus, and it'll be very clear to patients as we move along. As you come along that curve, you will see back how large the building is. The building is 512 feet long. So it's a huge building. If you take Cassich is a large building. It's about 376 feet, I believe. So it's almost 1.5 times the size of Cassich as far as the length, and it's obviously much wider too as well. So you can see we had to basically, and we looked everywhere, trust me. We looked to try to keep it inside the chassis. We looked to try to figure out what to do, but we couldn't plan for the future with the high acuity of our patients and all the other things that we needed to do and not have a new footprint. So we really needed to make a choice. And with the leadership of our C-suite and everyone else involved, we really felt this was the right thing to do. And so we have to look at this not in 5 years, but in 20 years. Where are we going to be in 20 years? And so as you move along, then you can see the rest of the campus. Behind it would be the pool pavilion. If you look at this area here, pool pavilion is in the back here. The ER entrance now is right here. This all gets changed into a brand new building, and you'll have observation discharge here at the end. So when you're admitted, hospitalized in observation, you'll be in this unit. And you'll be, now sometimes statuses change too, depending upon the patient, but we want the majority of those patients to be self-contained, have their own exit. They don't have to deal with the hustle and bustle of what's happening on the rest of the inpatient units. They don't get mixed with everybody else on the inpatient units, the higher acuity patients that are sicker. We try to keep them in a safer spot, in a more confined spot with private rooms and the ability to be able to heal quickly, and then try to get you home as efficiently as we possibly can as well. If you look at from the sky, I wanted to make sure I gave you a little bit of an understanding of what it would look like. If you look at this area here, this is the existing emergency department right now. This is the adult emergency department. This will all be for children. It'll all get reconfigured. It'll all look very childlike, of course, and be inviting for our children. It'll have its own entrance, like I mentioned. It'll have its own triage area. It'll actually have its own inpatient pediatric pharmacy too as well. On the adult side, as you can see here, it's a very large area. This is the 512-foot-long building. It has its own MRI. It has its own CAT scanner. It has its own lab so that we can actually get all these things done efficiently. We don't have to tube everything to other parts, which would be more efficient for our patients. It has its own stress testing area. It has its own cardiology infrastructures too. Many of our patients that are in observation unit have cardiac problems, and we need to work them up for that. The observation unit will be on the outside. In this section, the emergency department will be on the inside. There will be a psychiatric facility as well within that building. It'll be a 6-bed psychiatric unit. As you know, our psychiatric patient population has increased significantly over the years within the Valley and across the country. We need to be able to take care of our patient population. They are some of the very sickest patients that we come across on a daily basis. So we really feel we have a comprehensive plan. The trauma center, too, will also be moved. So trauma will be moved in the middle of this building. It basically will come right here. The helipad will come on top on the second floor, which will basically be right up above exactly where it's at right now. So it doesn't really change spots. It just kind of moves up a floor. So a lot of different changes, a lot of different things you'll find on the inside when you walk in. Your experience will be entirely different. And we're ecstatic about it. The other point that I was making about sicker patients, we actually are going to have its own intensive care area within this emergency department. All your stroke alerts, the pre-hospital stroke alert, we know exactly where they're going to go. All the MI alerts that come in, we're going to know exactly where they need to go. And it's very close to all the important diagnostic functions that happen within that system. So all these things were important to think through, and we got input from everybody, like every single person you can imagine. The challenge that we'll have is certainly the space. It's large, right? So how do we efficiently make sure that our patients are getting the tests and the things that they need as efficiently as possible is going to be a challenge for us. But we think we've put enough services within the building to be able to do that with that patient population. This is basically, if you're looking at the campus from outside, this is what the building would look like from the top in the upper right. This is how it would look coming into campus. Right now is the back of the emergency department is right here. It's located right here. This is all a new connection and all a new building here, 512 feet long. So if you think about where the volleyball courts are, I don't know if you guys know where they are, but that's where the edge of the building actually sits. And you can see it if you go back to the back. So that's the overall plan for the campus itself. If you want to know the difference of what we have now and what we're going to have when we're done, this gives you a depiction. As far as the adult emergency department, right now, we have 42 adult beds and 5 express care beds to see 68 to 69,000 patients per year. We will have 97 adult beds when we're done. We have 30 hallway spaces, by the way, and we see 55 to 85 patients in the hallway every single day. We wanted to remove that and get rid of that. It's not a patient satisfier. It's not the right thing for patients. The children's ER has 12 pediatric beds now, and we've had this children's ER since 2011, and it's been very, very successful in many ways for our patients. We will have 24 pediatric beds, and we'll have 3 resuscitation bays as well. As you know, when you're a children's hospital, you're going to get sicker pediatric patients. That was very important for us. Observation beds. Right now, we utilize 5C in the pool pavilion as our observation unit. We have 30 to 50 observation patients per day within the whole organization, within this chassis. We are going to currently have, 59 observation beds in this new facility. Now, you might say, why is 59? Like, why didn't you just make it 60 or 62? I mean, are you kidding me, 59? Well, when you start looking at bathrooms and all the other pieces that go along with that, we came up with 59. You wouldn't believe how much I talked about bathrooms every day about this, because it's important, right? And so Bill can attest that it was definitely, we tried to think about as many things as we possibly can. So it'll be 59 beds, and there'll also be 12 pediatric observation beds too, attached to this unit. So we're excited about that. The other features, of course, are the trauma bays. We'll have 3 trauma resuscitation areas with an ability to go to a 4th if we need to for growth. We'll have 1 code red room with basically an operating room within the suite itself, so those patients don't have to go to the general operating room population. They can stay right there and get their procedures done. And it has dedicated CT, MRI, lab, and X-ray, which I already talked about. So that's the exciting news that I have from an emergency medicine and hospital medicine perspective. We are so thrilled to be able to provide this for our community. We've already been out there, Bill and I have already been out there talking to people. We wanted people to be excited about this. This is something that in my lifetime I never could have dreamed of having the option to do that. And we have the ability to do that here for our community right here. This doesn't happen. This truly doesn't happen in many places. And we have a lot of other things happening in the future too, right? I mean, we have Norco, right? The Northampton County and what we're doing up there, which Terry talked about. There's stuff that's happening in Pocono. There's things that are happening all over the place that we're really trying to take care of our community the best we possibly can. And this is testament to the fact that we are truly doing that. So I'll stop as I've talked, and I could keep talking. And if it was you two up here, we'd be talking for hours because we have lots of stories. Yes, sir.
On the subject of observation versus inpatient, seniors on Medicare, if they enter emergency room and after numerous tests, the staff cannot determine what the problem is and decide to move the patient into a hospital room for observation and is kept overnight. Unless the patient is admitted, quote unquote, the Medicare will not pay for it. Mm-hmm. What's your advice? How should the patients be dealing with this issue?
So I totally hear your problem, and that has been a question. And some people don't even know they're in observation, right? So that's the other thing that we're trying to avoid, right? You're right, because you go to the inpatient unit, you think you're in observation, you think you're an inpatient, right? I get it. So one of the things that we've done as an organization is to try to understand and try to sort out what patients would actually meet criteria for inpatient instead of them being observation. Because if you've had lots of tests already done and there's a reason to keep you, there's probably more of a reason for you to be an inpatient than an outpatient observation patient. So we've actually started to convert, rightly so, a lot of the observation patients now to inpatient, to answer your question. Now, I'm not going to change the Medicare rules. I'm not going to be able to do that. But I think at least what we can do, and we can't put somebody inpatient that doesn't meet criteria for it. That's not the right thing either. We try to do the safest thing for the patient. We'll continue to try to do that. But I think the communication to you is the most important part. Like, you need to be understand and informed that you're in observation status, right? So that you can say, okay, I get it, but I can expect that Medicare is going to give me a hard time here, right?
The patient being informed while they're in a hospital room overnight.
Yep.
That they are in the observation classification and that the Medicare will not pay for it. Are they being informed? That was the main
Yeah, so they are in certain ways, though. But remember, people are sick sometimes, and they're not always, they're signing forms. And we actually, by law, have to let people know that they're in observation. Now, I think that what we could do better from an emergency medicine perspective is communicate to them better about that. So what this also communicates to them in another way, too. There's the verbal communication, and when you're sick and when you're having a difficult time, you're not listening and absorbing everything that people are telling you because they're asking you a gazillion questions. Sometimes you ask the same question 3 times, right? So, but this sends a message to them that you're staying in this unit, you're going across the hallway into the observation unit, and you're in observation. We have educated our emergency providers and as well as our hospitalists and the nurses up in observation unit. They have to communicate that with the patients that they're in observation. So that's why I put the topic on there, because it is a huge issue. And when we started to give this talk, a lot of people were like, oh, thank God. Now people are finally going to realize that they're actually in observation. They can understand what to expect, number one. And number two, we still have to keep looking at which ones can be converted to inpatient so that we don't run into those issues. Good question.
Other questions?
Dr. Burmeister, I just completed reading Dope Sick, and it discusses the opioid epidemic. Do we have special units for opioid overdoses, and what are we doing about it in the Lehigh Valley?
That's a great question. So we are fortunate enough, and they reside in the Department of Emergency and Hospital Medicine. We have 5 toxicologists. And those toxicologists have a passion for the opioid crisis. And we have really worked extremely hard to try to take care of that patient population because many times they come into the emergency department. So we've developed 2 things within the network. First of all, we have an opioid stewardship program, which really looks at trying to make sure that our providers are not prescribing opioids like we used to prescribe. We've put order sets together. We've put things together. We've set standards for them so that we're not becoming part of the problem. That's the first thing. Then the second thing is connecting the patients that do come in with opioid addiction into what we call a host program. It's basically we wrap our arms around those patients and give them options for treatment. So in July 1 of this year, we started a program here with our toxicologists because one of the biggest issues that we've had across the country is having physicians that can actually be trained enough to treat these patients because it takes a lot of time and effort to be able to do that, and it's a specialized type of area. All 5 of our toxicologists are X-waivered. That means they can treat patients with other forms of medication outside opioid. We started a clinic which opened up, and we are in collaboration with the Pyramid, if you've heard of Pyramid Healthcare. They deal with all the other types of issues that we need to, like psychiatric infrastructure, social services, how do we get people housing, because many are homeless, and all these things we've put together in concert with them. And our toxicologists are now treating these patients. It's incredible, right? And once you start something, it can really go crazy. We have treated over 120 people already, and they're on a regimen outside the opioid use. Now, we have to look at how successful it's going to be 5 years down the road and 3 years down the road. We've put things into place. We have a drug and alcohol inpatient unit, 2 inpatient services at Schuylkill. But it's difficult to find inpatient services anywhere in the country. It's been very difficult. So we've been doing that from an outpatient perspective. We have actually a lot of infrastructure in place here. we have been known across the state to be the leader in this opioid crisis. Jillian Beecham is our toxicologist who leads this program. And now we're starting to develop a center of excellence too as well, because we really feel it's our duty to be able to take care of these patients. We see them every day in the emergency department. That's a great question. And I'll tell you what, people are struggling with this across the entire country. And Pennsylvania, quite frankly, has been pretty slow to the game. But we're getting there, and we're getting a lot of support too from our counties. At Lehigh County, we have a good relationship with them, and also from the state and national resources.
Okay, we are at time, but can we squeeze in maybe one more question?
Sure.
Okay.
Dr. Baumeister. My name is Ellen Kalinowski. As an ambassador, I'm challenged sometimes with the expansion of the emergency room. That people are asking me, how, are you expanding the doctors? I didn't see anything on the charts in that, and I'd like to be able to respond to them.
Sure.
And so as being a patient myself many times and gone to the emergency room, they challenge me with that question, that the wait time is long.
Mm-hmm.
And so how is it going to improve with the new emergency center if we're doubling and tripling the beds?
Yeah.
What are the plans in that?
Sure. So just to be clear, and that's actually an incredible question. I just came from a meeting that people were asking me the same question. So we can't fill the 97 beds day one, right? We're at 59 now, but we are adding physician staff for sure. We'll add 2 FTEs, which will be 1 shift to be specific, to accommodate the patients that we think that we're going to get the day one when we open. We will add physician coverage when we need to. Like if the volume comes up, we will add physician coverage. A lot of times though, what you find out, whenever there's long wait times, not that people are very busy in that ED, and you've probably seen it if you've ever been in there. But it's not always about physician staff availability. It's about space availability, right? That's one of the biggest challenges that we have. So we have physician staff that we can flex. We're fortunate enough that we hired quite a few staff for this expansion already. We pre-hired them. And we also hired people for the other project too that we're dealing with. So yes, we will be adding physician staff. We won't be staffing all 97 beds day one. This is obviously for the future too as well. There may be days and times during the year that we have to staff the whole thing. But that depends upon seasonality too, right? In the wintertime, we tend to get sicker patients, more acuity, higher volume numbers. And in the summertime, not as busy in emergency departments, lower acuity, not as sick because the respiratory virus season's not in play. So yes, absolutely. And there will be nursing staff and support staff and other staff that we put in. Actually, when you look at a business plan like we put together for this process, almost the biggest expense, certainly the capital expenditure is huge, but the biggest expense is staff, the staffing of it. So I hope I answered your question.
Thank you so much.
Yeah, thank you, everybody. It was nice to meet everyone. Take care.
Thank you, Doctor. Very interesting presentation. And that's why you're here today, folks. You're advocates for all that you've learned from Dr. Baumeister, also from Terry Capian, from Terry. You go out and you talk to your friends in the community and tell them what's going on out here at this hospital. So to our guests, we had 4 or 5 of them today, which is wonderful. If you enjoyed today's presentation and you have an interest in becoming a member of the Board of Associates, please complete an invitation for general membership form at the registration table with the member who invited you. Our next meeting will be Wednesday, April 10th, back here in Lehigh Valley Hospital, Cedar Crest. I would be remiss if I didn't thank Max for taking care of all the tech stuff today so that you could hear what was going on. Is the reception better than what it used to be? Okay, Max, you hear that? Yeah, thank you. Okay, now, I do challenge you to take this home with you. Don't leave it on the desk. Take this home and read it and share it with your neighbors, friends, and relatives, because there's all information in here. And let's see. So anyhow, in closing, happy Valentine's Day tomorrow. May your day tomorrow be filled with love and happiness. Good day.
No problem.